Welcome to AETCM, the emergency medicine channel. Today let us discuss about cardiac failure. We'll see what are the clinical findings you see in different types of cardiac failure and how do we manage that case in emergency room. So when we discuss about cardiac failure, we should know the definition of cardiac failure. It is defined as a state in which the heart cannot maintain an adequate cardiac output. So heart is not able to maintain the cardiac output for the body, or it can do so with an elevated filling pressure. Only if the filling of the ventricle is increased or pressure is increased, then only it can maintain the pumping. So either the pressure has to be increased in the ventricle or it has to pump more. But ultimately whatever happens inside the heart, it is not able to maintain the systemic circulation. That is cardiac failure. The heart failure can be again subdivided into systolic failure. So that in systolic failure, heart is not able to pump blood from the left ventricle to systemic circulation, or diastolic failure. Diastolic failure is the filling is not proper, like a patient who is having a cardiomyopathy. The ventricle is not able to enlarge, so the amount of blood which is coming to the ventricle is restricted. So that is diastolic failure. Heart failure may be caused by myocardial failure, but it may also occur in the presence of near normal cardiac function under conditions high demand. So that is the second part is like high demand conditions are like pregnancy, anemia, thyrotoxicosis, beriberi. All these conditions, heart is actually normal, but the need of blood is more. So the pumping, the amount of pumping is not able to maintain the systemic circulation. So that is high output cardiac failure. The other one, heart failure, may be caused by myocardial failure. That is low output failure. Heart is not able to pump the blood, but other condition, heart is able to pump more and more, but even then the peripheral tissues are not getting blood due to some other reason, like pregnancy. You need to pump more because there are two lives, mother and child is there. So the requirement is very high. So the heart is not able to maintain that amount of blood for systemic circulation. Again, it is divided into right ventricular failure and left ventricular failure. So in clinical practice, the most of the time what we see because of ischemic heart disease or cardiomyopathy or alcoholic cardiomyopathy, whatever it is mostly left ventricular failure. In left ventricular failure, left ventricle is not able to pump the blood to the systemic circulation. So if you see the left ventricular failure, you can see the heart. This is the heart. Then this is the left ventricle. From this left ventricle, blood will be pumped out to the systemic circulation. So left ventricle is not able to pump to the systemic circulation. That is left ventricular failure. Whereas right ventricular failure, what happens? You have IVC and SVC. So both the veins will send blood to the right side heart, and if the right side heart is failed, you can have ascites, you can have splenomegaly, you can have hepatomegaly, you can have pedal edema. Whereas SVC is not able to bring the blood to the right side of the heart, the JVP can be elevated. Whereas the left ventricle fails, the back pressure increases on the left atrium. That back pressure go to the pulmonary circulation, and there patient can have pulmonary edema. So pulmonary edema will be one of the important feature of left ventricular failure, whereas ascites, splenomegaly, hepatomegaly, pedal edema, raised JVP will be the feature of right ventricular failure. So the most important clinical finding in left ventricular failure, which patient can come to the emergency room, will be pulmonary edema. So pulmonary edema occurs because of the back pressure, which increases the pressure in the left atrium. From left ventricle, back pressure increases to the left atrium. That back pressure increases to the pulmonary circulation. So pulmonary circulation, when the pressure increases, patient can have pulmonary edema. So these patients can have dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, and pulmonary edema. This will be a cycle. Initially, patient can have dyspnea on exertion, unaccustomed to work, Then accustomed work patient can have dyspnea on dyspnea. Then routine work patient can have breathlessness. Then rest patient can have breathlessness. In rest again patient can have paroxysmal nocturnal dyspnea. Any time in the night patient can have breathlessness, and afterwards patient will have orthopnea. Immediately after lying down itself patient can have breathlessness. This is called as NYHA classification. NY, New York Heart Association classification. So type 1, class 1, class 2, class 3, class 4. 1 is unaccustomed work. On an unaccustomed work patient is having breathlessness. Then an accustomed work patient is having breathlessness is class 2. Then on routine work patient is having breathlessness, that is class 3. Then on rest patient is having breathlessness, that is class 4. Again here patient can have paroxysmal nocturnal dyspnea. So there is a first phase of class 4, then patient can have orthopnea. So there is a last stage of classification, orthopnea. Now other than that, patient can have pleural effusion, patient can have central cyanosis because of cardiac failure, cold peripheries, because most of these patients who is having cardiac failure, initially itself patient heart will try to maintain the systemic circulation by increasing the heart rate, that is tachycardia, and increases the peripheral circulation by constriction of the peripheral arteries. So both can increase, so peripheries will be cold and tachycardia will be there, and systolic BP will be low. So that is very important, systolic BP will be low. Some patients even diastolic BP also will be low. Most of these patients can have S3. So S3 gallop, normally when you auscultate you get S1, then S2, then S3 is normally not seen when you are auscultating, but in a failing ventricle, this is one of the signs, that is S3 will be present. Now right ventricular failure, we have already seen that right ventricular failure means, so this is the right atrium, right ventricle. From right ventricle blood will go to the pulmonary circulation, from there it will go to the left atrium, then left ventricle. So due to some reason, if the left ventricle is failed, so it can be due to cor pulmonale, that is a lung disease leading to ventricular failure. It can be an acute cor pulmonale, like a patient can have pulmonary embolism. It can be a chronic cor pulmonale, that is seen in chronic lung diseases like COPD, ILD and all. Tricuspid regurgitation is another important condition where patient can have right ventricular failure. So what happens is, so there is SVC, this is IVC. So all these things, blood will be drained to the right side of heart. If this ventricle, right ventricle is failed, the pressure will build on the right atrium. Then the blood normal course, it is going without any problem. But here the pressure is already high. Blood cannot go to the right atrium. So JVP is the first thing going to increase. So jugular venous pulse will be increased. So you may get hepatomegaly, you may get splenomegaly, and ascites can be there. Ascites can be there. Then patient can have pedal edema. So pedal edema also can be there. But once you give Lasix, this fluid will be removed. But even then minimal failure is persisting. So if you press on the abdomen, this is called as hepatojugular reflex. You press on the abdomen, so you can see the JVP will be slightly elevated, and persistent elevation of JVP can be there. So that is called as hepatojugular reflex. So that is right ventricular failure. Now high output and low output failure. Most of the cases what we see in our practice will be low output failure. Ventricle is not able to pump. This is because left ventricle is mostly dilated. So normal ventricle may be this one. So due to some reason like due to acute coronary syndrome or alcoholic cardiomyopathy or cardiomyopathy itself, ventricle is dilated. So when ventricle is dilated, the pumping ability, the muscles are thinned out. So pumping ability is reduced. So the pumping is reduced. This is called as systolic failure. So that is systolic failure, but it is a low output failure. Output is actually reduced. If a normal ventricle is pumping 100%, just imagine it is 100%. When the ventricle is dilated and thinned out, the pumping may reduce to only 50%. So this large amount of volume is there, but ventricle is not able to pump that much. So it will become only 50%. Okay. If you see the ejection fraction, normal ejection fraction will be somewhere around 55 or 50. Now the ejection fraction will be grossly reduced to 40, 30, like that. It will be reduced. So if you do an echo, ejection fraction will be reduced. So that is low output failure. Whereas some conditions like anemia, thyrotoxicosis, pregnancy and all, the ventricle is actually normal. Ventricle is normal, it is not dilated, but the requirement is very high. Like pregnancy, instead of 100%, this patient may require 150%. For just for a example, I am not telling the exact numbers. So 100% is a normal pumping, but when the person become pregnant, the requirement may become very high. So that much amount anyway ventricle is not going to pump, normal case, but our body will try to pump as much as possible. It may not reach up to 150%, but it may reach 140, 130, like that. So then there is a failure that is called as high output failure. Heart is trying to pump more and more, but the requirement is very high. That is high output failure. You get it in conditions like thyrotoxicosis, pregnancy, beriberi, anemia and all. And that pregnancy is a physiological condition, most of the time it will be compensated. But anemia, unless until you correct the anemia, or thiamine deficiency, you correct the thiamine deficiency, thyrotoxicosis, you correct the thyrotoxicosis, patient will deteriorate. Now on examination, what are the findings you are getting? So left ventricle failure means, you should remember, left ventricle failure means left ventricle is failed. This back pressure will go to the left atrium, that back pressure will go to the pulmonary circulation. Patient is going to get pulmonary edema. So patient can have acute breathlessness. They come to the emergency room with severe breathlessness. On auscultation, you can get bilateral crepitations. So that will be the classical finding. And on auscultation of heart, you can get S3 gallop, S1, S2 is normal, S3 gallop can be there. So that is a common finding. But many patients who is having left ventricular failure can also have right ventricular failure, because when the left ventricle enlarges, it even pushes the right ventricle, and size of the right ventricle can be sometimes reduced. And even the back pressure from the pulmonary circulation can come to the right ventricle, and right ventricle also will have more pressure. So right ventricle failure can be associated with left ventricular failure. Whereas in right ventricular failure, you don't get pulmonary edema, you get elevated JVP. Hepatojugular reflex can be positive. Then hepatojugular reflex means minimal fluid overload. If the fluid overload increases, you can get elevated JVP. Hepatomegaly, splenomegaly, this is called as congestive hepatomegaly, congestive splenomegaly. Then ascites can be there, then pedal edema can be there. So these are the common findings, and if you see the pulse will be very feeble in left ventricular failure. BP will be, systolic decapitation can occur because systolic BP will be very low, and even diastolic BP also can be low, and sometimes patient can go to shock. Left ventricle apical impulse may be shifted out and down, that is because of the dilatation of the ventricle. Now features we have already seen, I have already explained in detail. Since the circulation is low, patient can have fatigue, exercise intolerance, dyspnea on exertion, orthopnea, PND, pre-syncope, syncope, palpitation, angina. So these are the common symptoms. Features of right ventricular failure: pedal edema, ascites, elevated JVP, hepatic congestion, hepatosplenomegaly, hepatojugular reflux. Features of LVF, that is mainly pulmonary edema, basal crepitations. Now this picture tell you that all the findings we discussed there in this picture, but some of the things we already discussed. So many things like dyspnea on exertion, orthopnea, bilateral creps, BP can be reduced, nausea, vomiting, that is because of the increased abdominal pressure, ascites, pitting pedal edema, pulse is low, spleen, liver enlarged, S3 gallop very important, tachycardia, fatigue, jugular venous distension, JVP is elevated, confusion because of reduced blood circulation to brain, anxiety. Now, once you see a cardiac failure, we should identify what is the cause for cardiac failure. That is very important, because we already seen that some high output states like thyrotoxicosis, anemia, pregnancy, then conditions which can precipitate heart failure. One of the important conditions is hypertension and tachycardia. You should think that how cardiac tachycardia, like tachycardia increases the failure. Because whenever there is a minimal failure, if you reduce the heart rate, heart can pump, expand slowly and pump slowly. But if you increase the heart rate, the diastolic phase will come down, so the filling will be reduced. So if heart is pumping very fast, the diastolic phase is reduced and pumping will be reduced, so that will lead to cardiac failure. So in any cardiac failure, minimal cardiac failure, which can be aggravated by tachycardia. So we should be very careful. Regurgitating heart lesions, valvular lesions, alcoholic cardiomyopathy, drugs like verapamil, diltiazem, they are calcium channel blockers. They can reduce the pumping. Beta blockers in higher doses, but beta blockers are treatment for cardiac failure because it reduces the heart rate and so that the pumping can be increased. But it should be started with very low dose and titrate the dose upwards. Whereas verapamil, diltiazem, they are calcium channel blocker. They are very dangerous in cardiac failure. Atrial fibrillation or any other condition where there is tachycardia can be dangerous. Now, coronary artery disease, smoking, hypercholesterolemia, weight gain, high BP, diabetes, all these things are dangerous for cardiac failure. So, all these things should be controlled. Now, once you diagnose cardiac failure, the immediate investigation in emergency room, the treatment is different, that we'll discuss afterwards. The immediate investigation in emergency room will be, one important thing is BNP. So BNP is one test which is not given in this chart. BNP is one test which will tell you that the cause for breathlessness, so because the breathlessness can be due to asthma, COPD, pulmonary embolism and cardiac failure. So if it is due to cardiac failure, BNP is going to elevate. So one of the important tests which should be done in emergency room to diagnose, if you are not clinically able to diagnose only. If you are clinically able to diagnose, no need to do that. If you are not able to diagnose clinically because you have multiple problems like COPD patient coming with cardiac failure, then BNP may be helpful. Other investigations to rule out the precipitating problems: hemoglobin, thyroid function test, hyperthyroidism or hypothyroidism, potassium, magnesium, sodium should be checked, creatinine to rule out renal failure, because renal failure also you can have pulmonary edema. Chest X-ray should be done, that we'll see afterwards. ECG, ischemic changes and tachycardia. Treadmill test, if patient is not having symptoms on that day, you can subject the patient for treadmill test. Echo should be done to rule out LO ejection fraction, and in any valvular lesion, USG abdomen should be done. Look at this X-ray. This is the heart border. You can see the heart border. Heart is already very much dilated. You can see the transthoracic diameter is more than, the the cardiac diameter is more than 50% of the transthoracic diameter. So that is cardiomegaly, and lot of non-homogeneous opacities surrounding the heart. Okay, so that is pulmonary edema. If you give Lasix and NIV, non-invasive ventilation, or BiPAP or CPAP, it can be easily relieved. You can see here interlobar fissure. So this is interlobar fissure. So that is interlobar edema. This is a classical finding seen in cardiac failure. Sometimes the whole interlobar fissure will be like a tumor. You can see a white shadow throughout this area. So this is called as vanishing lung syndrome or phantom tumor. So the whole area will be like a tumor. So that also you should remember. Now BNP, we have already seen that it is elevated in cardiac failure. One of the important investigation, more than 500 picogram per ml is generally considered as positive. The advantage of this one BNP is, when you have a patient who is having cardiac failure with asthma, cardiac failure with COPD, cardiac failure with some other disease, the patient coming with acute breathlessness, if you want to make a diagnosis, proper diagnosis, BNP will be very useful. But remember, BNP can be even elevated in renal failure. because renal failure itself can present with acute flash pulmonary edema. So there it will not be very beneficial. But if you see the treatment for renal failure induced pulmonary edema or cardiac failure induced pulmonary edema in emergency room, both are same. You start Lasix, you give NIV ventilation, it will relieve the symptoms mostly. Now, any patient coming to emergency room, we have to take care of his airway, breathing, circulation. So, oxygen should be started. Look for any oral cavity secretions. All these things should be removed. Then patient should be in a propped up position. This is very important position. Anybody who is coming with breathlessness, whatever may be the reason, we have to keep the patient in propped up position. So, the posterior part of the lung and anterior part of the lung will be freely moving. Even upward movement also can be facilitated, and you have to give a cardiac table. Patient can lie down on the cardiac failure. So propped up position, cardiac table, these are the two important things we have to provide. Sublingual NTG can be given, or NTG infusion can be given if the BP is high. So how it is going to help, that we should remember. So pulmonary pressure is increased. So if you dilate the blood vessels, some amount of blood fluid can go to the dilated vessels. So the pressure here may reduce, and even it may increase the coronary circulation. So NTG may be helpful in some condition where the BP is very high. Furosemide is a very important drug, that is Lasix injection furosemide, that removes the fluid from the systemic circulation. But if there is no renal output, this is not a good drug. You have to go for dialysis. Then dobutamine and dopamine. Instead of dopamine, you can go for noradrenaline and dopamine. The advantage of dobutamine is dobutamine increases the pumping of the heart. But there is a small side effect. Initially, it can produce peripheral vasodilatation. So some patients can go to acute shock during the acute initiation of dobutamine. To prevent that, previously we used to start dopamine. But nowadays, most of the patients who is having hypertension, noradrenaline is the first choice. Maintain the systolic BP around 100. Then start dobutamine, slowly increase the dose so the pumping will be increased. So that can be started. Non-invasive ventilation is the most important strategy in emergency room in all patients who is having breathlessness, whether it is cardiac breathlessness or pulmonary breathlessness or any other reason for breathlessness, even central cause for breathlessness. The patient is conscious, oriented, without a pneumothorax risk, then you have to go for non-invasive ventilation. So NIV, I am not going to the details of NIV. So initial settings will be usually in the range of tidal volume should be kept into range of 5 to 7 ml per kg. IPAP, EPAP start 10 by 5. Pressure is less than 8 centimeter water, bar 4 centimeter water not advised. So start 10 centimeter water or 5 centimeter water will be adequate. So other things we'll discuss in some other class. So NIV should be started as early as possible so that patient will improve without much problem. But only thing is, patient should not have altered behavior or coma. That is very important. There should not be any risk for any pneumothorax. So predictors of success, that is very important, like decrease in PaCO2 greater than 8 millimeter of mercury, improvement in pH greater than 0.06, correction of respiratory acidosis within 1 to 2 hours. If that is not attaining, then we have to intubate the patient. So that is very important. Intubation criteria is given here. And contraindication NIV, we have already seen patient should not have coma, cardiac arrest, respiratory arrest, any condition requiring immediate intubation. So that we have to take care, NIV should be started. Now fluid reduction strategies. So you can give restriction of water and salt, 1 liter fluid per day, 2 grams salt per day, that is a restriction of salt and water. Then diuretics, most important diuretics we have already given furosemide. So on follow-up you can give hydrochlorothiazide. So one important drug here we should remember is spironolactone. It's actually a potassium sparing diuretic. That reduces the fluid retention in the body. instead of other drugs, you can start this along with furosemide. Furosemide removes fluid, but spironolactone actually prevent the retention of water. Secondary hyperaldosteronism can be reduced, and it has got some preventive action on the ventricular remodeling. So spironolactone should be added to all regimes in cardiac failure. Another important drug in any cardiac failure you should start is ACE inhibitor or ARBs. So that is very important. ACE inhibitors stabilize the ventricular remodeling. That is very important step. All patients who is having cardiac failure or post myocardial infarction, you have to start ACE inhibitors or ARBs that stabilizes the ventricular remodeling, that prevents the ventricular dilatation. Only thing is it should be avoided in patients who is having elevated creatinine. Even in pregnancy we should not use this drug. Now another important drug is beta blocker. Normally beta blockers should not be started in cardiac failure, but in a patient who is having cardiac failure, not severe cardiac failure, you can start beta blocker, like you can start carvedilol 3.125 milligram slowly and step down the dose. What happens is, this is patient is having tachycardia, like heart rate is 150. When you start low dose of beta blocker, slowly the heart rate may come down to 140, then after sometimes 130, 120, 100, then 75, like that you increase the dose, so that slowly the heart rate comes down. What happens is, when the heart rate comes down, the demand of oxygen by the myocardium actually reduces, so that gives good output. So long term output with beta blockers are very good. Carvedilol or metoprolol you can start, but remember, we start with very low dose, titrate the dose upwards. Same thing we have to do in AC inhibitor or ARB, because higher doses can produce hypotension, shock and all. So start with very low dose, increase the dose. Now digoxin should be started in patients who is having cardiac failure with tachycardia, especially atrial fibrillation with tachycardia. So this is one of the important drug which can be useful in all cardiac failure, but because of its side effects. At same time, it is a antiarrhythmic drug. So it is an antiarrhythmic drug, but same time it is a proarrhythmic drug. That means it itself can produce arrhythmia. So we don't use digoxin nowadays in all conditions with cardiac failure. The actual indication for digoxin nowadays is atrial fibrillation with cardiac failure. But even now many doctors use in patients who is having cardiac failure, digoxin is used. Many patients get benefit because patients overall symptoms improve. But only thing, we have to closely monitor this patient, because digoxin itself can produce many types of arrhythmias. Now sympathomimetic agents, normally we start dobutamine. So that is a drug we use in emergency room, but it will be always with noradrenaline. So start noradrenaline in acute condition, increase the systolic BP to 100, minimum 100 millimeter of mercury, then start dobutamine. So dobutamine increases the cardiac contraction, but it also dilates the peripheral circulation. So if you start only dobutamine in a patient who is having pulmonary edema with hypotension, there will be sudden hypotension, patient may collapse also. So to prevent that, you start an noradrenaline, slightly increase the BP, then start dobutamine. Another drug is milrinone or levosimendan. All these things are very costly drug. There is no added advantage over dobutamine. That's why we don't use this type of drugs very commonly. But these drugs are available in our country. So we have discussed about patient who is having cardiac failure, how to manage different types of cardiac failure. I have not discussed forward failure, backfired failure, so many other types of failures also there. But for a general purpose, general practice in emergency room, this much is enough. So cardiac failure, what are the clinical findings? RV failure, LV failure, how to treat these patients in emergency room, and follow-up is also very important. These patients require only graded exercise. You should never advise the patient to do heavy exercise immediately after discharge. You should ask the patient to do graded exercise. The advantage of graded exercise in patients who is having cardiac failure, especially due to ischemic heart disease, the formation of collaterals in the heart muscles are very important, because when one artery is blocked, if there are large number of collaterals which can supply the same area, patient can survive better. But if you are not advising exercise, the collateral formation will not be so powerful. So the circulation will not be so powerful. Collateral circulation development will not be powerful. So patient can collapse even with a small injury in the coronary circulation. So remember to advise graded exercise, physiotherapy, breathing exercise, all these things. Thank you.